down to just some of the gap balancing. I know that's a really high yield topic with total knees, and then a heavily tested question, as well as a something that actually comes to play when you're actually doing the case and you have to worry about balancing. Can you kind of talk a little bit about how we balance with our flexion and extension gaps? I think Jay has a something here.
Yeah, so that's like we talked about at the beginning. Our goal is getting a knee that lines up with the mechanical axis and getting a rectangular flexion gap, a rectangular extension gap. And what I mean by that is that it's equal, that it's balanced in both the medial and the lateral compartment. And if you can come out of the surgery with a knee that lines up with the mechanical axis and it's symmetric on both the medial and lateral compartments, I think you've hit a home run for a knee replacement and accomplished kind of the main goals for giving the patient a good outcome. So, there's a lot of things we can do to balance the knee. And so if we're making these bony cuts, let's say we make our distal femur cut at 5 degrees and we make our tibial cut perpendicular to the axis of the tibia, those are our bony cuts. That doesn't affect our balance. Our balance is derived from soft tissue balancing. So everything you do during the operation has some effect on soft tissue balance. You approach the knee, you're getting ready, you make your arthrotomy, you're down, and before you do your medial release, it's important to think about what kind of deformity does this patient have. If they have a mild varus deformity, if they're neutral, if they have a valgus deformity and they're really lax on the medial side, before you do that medial release, you have to think that every soft tissue that you release off the medial side is going to loosen up that medial side. So even from our approach, we have to be thinking about balance. You go down, you make all your cuts, taking out the making sure you get all the meniscus, making sure you don't release popliteus. If you release popliteus, that'll loosen up the lateral side in flexion. That's a surgical technique thing that you have to be cognizant of as you work through the surgery and try to balance the knee. And then, as more and more of us are putting in cruciate stabilizing designs, what do you do with the PCL? So some people will leave the PCL. The problem with the PCL is it tightens down the lateral compartment. It also tightens the knee in flexion. So if your flexion space is too tight or you're too tight on the lateral side, that's another option. You could release the PCL. Some people leave it. Some people selectively release it, or what you would call balance the PCL, only release it if it's tight in flexion, tight on the lateral side. And some people release it every time. So it's really surgeon dependent, but you have to know that those are the three reasons why, or three options that we have and why they're done, and which one are you going to choose when you're out in practice. And ultimately, if you're in a training program, that's what you're experiencing all this to decide, is that what I want to do or is that not what I want to do? So those are the kind of main things. So, let's say, for example, we have a really big varus deformity and we want to loosen it up. We're really tight on the medial side and we want to loosen it up. What can we do? So you can do a bigger medial release. You can get down to the hamstrings. You can release the hamstrings. You can get to that. We can really externally rotate the tibia and very much release that kind of posterior lateral corner. Posterior medial corner. You can take osteophytes as well. The other technique, if you have a really big varus deformity, there's something called a medial reduction osteotomy, where you actually osteotomize some of the bone off. You shift your component laterally, you downsize your tibial component, and just by doing that, by downsizing the component and taking that bone, you've loosened up the MCL and the pressure on that MCL. So just by that nature of downsizing and lateralizing the tibial component and downsizing the tibia with the osteotomy, you loosen up that medial side. The other thing, make sure your tibial, these are like little specific things that, you may not learn or you may not get told, but like, for example, if your tibial tray is oversized, that's going to put tension on the MCL. That could potentially add more tightness on that medial side. And so that's kind of more looking at coronal plane balancing, and looking at sagittal plane balancing. Some other things are, look at your tibial slope. If you cut more tibial slope, you're going to loosen up the implant in flexion. If you take more distal femur, you're gonna loosen up you'll loosen up the extension space. So for example, if someone has a 10 or 15 degree flexion contracture, a lot of the times I'll just say, hey, take 2 more millimeters off the distal femur. This will loosen up our extension space, which will allow us to get to neutral. Which, that's one of the goals too of these patients, is they want to be able to get their legs straight. So I think that's important. But these are all things kind of that stem from that physical exam, stem from that radiographic exam, and ideas that you have to have in your head before you go into the surgery in order to get a good alignment, a good balanced knee. A couple other things, that you'll see on OIG questions is, the flexion space is tight. What can we do? So if you have a size, a size 7 femur on, that number 7 denotes the anterior to posterior diameter of the implant. So if you downsize the femoral implant, you're gonna loosen up your flexion space. I would say the most common time that is used, the upsizing or downsizing of the implant, would be in a revision case. A lot of the times when you do revision cases, the underlying problem is that you're loose in flexion, so you may want to upsize your femoral component and add on some posterior augments. But those are kind of like the basics, bread and butter basics of balancing the knee, and kind of what you have to think about to give a good rectangular flexion and rectangular extension space. Yeah, go ahead.
I was just going to say, like even mentioning the change in the size of the prosthesis is just because the main difference is in the AP diameter. Is that correct? And that's why it makes a difference in more so the flexion gap, but not so much the extension gap. Is that right?
Yeah, so the distal aspect of the implant is always the same. It varies from company to company, but so for example, the implant that I use, you put the implant on, doesn't matter what size it is, it's adding 10 millimeters to that distal femur. So as you go up in number from a size 1 to 2, 2 to 3, 3 to 4, you're growing into your posterior, but you're not adding anything distally. And so that flexion space is slowly tightening and slowly closing down, but you're not really affecting the extension space because it's still 10 millimeters of metal on the end of the femur.